Okay, we should be live now. Good morning, everyone. Welcome to TeleShadowing. We are live on YouTube. Please feel free to ask questions in the chat box as we go along, and they will be addressed. I'm honored to introduce our mentor for today, Dr. Haft. Dr. Haft has served as many roles in the Maryland Department of Health. Actually, during the COVID-19 pandemic, he served as the medical planner for the United Command and lead on the Vulnerable Populations Task Force, and now serves as a senior medical advisor at the Maryland Department of Health. Dr. Haft is also a board-certified specialist in both internal medicine and emergency medicine, which we will learn about as well. And he's recognized by the American Board of Physician Executives as a certified physician executive and as a fellow of the ACPE. He served as adjunct professor in the McDonough Graduate School of Business and as an assistant professor, clinical professor of medicine at the Georgetown University School of Medicine. Dr. Haft has also served as a founder and chief medical officer of ConMed Healthcare Management, and he served as the president of Maryland Healthcare, which is a multi-specialty clinic in Southern Maryland, as well as president of the Maryland Foundation for Quality Healthcare. With all these many hats and chief executive roles, I'm very excited to have Dr. Haft join us. And now it's my honor to request Dr. Haft to begin today's session. Thank you.
Manahil, thank you so much for that very kind introduction. And it is a pleasure, absolutely a pleasure to be here and be able to chat with young students and those who are interested in healthcare and those who are interested particularly in understanding how we can make healthcare better in this country and be able better to serve our population, and hopefully along the way learn how important it is to be able to both understand how policies guide the long-term direction of healthcare delivery, and also how you can be involved in policy making and be part of the architects of the future of healthcare delivery in this country. I'll start by just saying again that I'm honored to be able to chat with you all today. And I think it's very important to have these kinds of discussions. I think, as we all know, healthcare is a really important piece of everyone's life. In most countries, in most nations in the world, healthcare is actually a right that people have. In the United States, it's not a right, it's really a privilege. And because it's a privilege, it really changes the dynamic in terms of how healthcare is delivered. When healthcare is a right, as think about the UK and National Health Service, everybody has equitable access to that care. When it's a privilege, think about that word privilege. That means that the privileged certainly have a right to that, but we need to be able to be very intentional about having policies and programs that allow healthcare to be delivered in an equitable way to those who perhaps are not privileged. So that's not to say that policy is not important in places where healthcare is a right, but it is really important in places like the United States where healthcare is still a privilege rather than a right. So with that preamble, what I'd like to do is to show you how all of the influences that you have in your life, starting from the very earliest, will be part of that journey that we're all individually on, but all of those individual impacts and parts of your life that you experience will ultimately color where you're going to land in terms of your inclination to either to make policy, or if you're making policy, in what direction that policy will lean. So let's go on to the next slide. So I think I will show you on the course of the next few minutes that we're together my what I would call very checkered life that's really served to in many ways guide my views on policy and also make me very intent on at every opportunity to be able to impact policies, particularly regarding healthcare. And I think this Robert Frost poem that is familiar to everyone is where I think you'll see there's a theme in these presentations, that when two roads diverged, I took the less traveled one. And each of us has an inclination to when you come to those crossroads to take one road or another in various and sundry ways. But those roads that you take will very much color your life, your experience, and also your views on how you want to impact the rest of the world. So let me tell you my story and then see if it makes any sense to you. And then we'll talk along the way about policy. And I'll try and highlight how even though at the time events occur, they may not really be in your mind in terms of, well, this is something that will guide how I look at policies in the future. How they very well may do so. Next slide, please. So now I've dated myself. I was born in 1949 and in Newark, New Jersey, and lived in public housing. This is a picture of the public housing that I lived in. It's not, I can't, this is taken out of an archive. It's not out of a family record. So I can't say that that's me and my sisters playing in the front yard there. But and what's not in this picture is actually right behind this was another very high-rise public housing project. We felt privileged to be in the front of the public housing in a supported apartment. But it was an interesting time in the late 40s, early 50s. People returning from war. I'm one of those baby boomers, obviously. Father was in the Navy and stayed in the Navy for a while, even after the war. And you know, I think very modest in terms of incomes, but felt very, you know, very comfortable. What things that kind of guide that I think back about at this time in my life, that much that I can vividly recall, was a lot of times playing outdoors and but also times of being cautioned at this time in the history of the world about in the springtime not playing in puddles because of the risk of polio. We know that polio is not caused by puddles, but it was a viral disease. But we had many children that I played with at that time who succumbed to polio, and think about iron lungs and those kinds of things. And it was, and then came lining up for vaccines, different kinds of Salk vaccines and others to combat polio. So the ability to really, to see the effects of a viral pandemic and then see how interventions can stop that kind of pandemic was one of those indelible kinds of things that imprint on you. Also during this time in the early 50s, going to school, we would regularly have things called air raids because there was a concern about nuclear war. And in air raids, the schools would once a week, once a month, whatever the periodicity was, would have all of the children go into the hallways or under their desks and put their jackets or coats over their heads in case there was a nuclear explosion. We never really understood if there was a nuclear explosion, how putting your jacket over your head or being under your desk would make a difference. But just the threat of having to regularly do that with the risk of a nuclear explosion actually was a very impactful kind of event. And so on. So, this was early things when you think about how, events in the world impact different and policies that drive those events impact our lives. There's just a couple of examples. The Cold War events and the policies associated with the Cold War clearly have indelible kinds of impacts on me and how I think about the world, even from the earliest days. Next slide. So grew up in a very large family. And after Dad left the Navy and everyone came back, my grandfather was a Polish butcher, and at butcher shops, a couple of butcher shops actually, been totally family supported. Everybody in the family, the children, the grandchildren, cousins, everybody worked in the butcher shop and learned the trades of going to the abattoirs and finding meat and how to process meats and cheeses. It was really a very just a very loving, hardworking kind of ethic that really was very, again, impactful on my life. That, well, both in terms of family and the challenges of big families, always some conflict someplace, always some drama, uh, always some internal, although there's harmony, there's also diversity, but also, tremendous shared effort for a unified purpose. In this case, unified purpose was to make enough money to support everybody in whatever their lifestyle was. And of course, in those days, this lifestyle was rather humble, and the work was 7 days a week, 7 days a week, and it didn't have any limitations on hours or on the amount of effort that you would put in. It was just doing the work until the work was done, and a lot of mutual support. So that was really very, those kinds of lessons stuck with me through everything that I've done in my life, and I think also made me think about, in many ways, about what are the things that allow us in this country to have this kind of independent business, and what are the things that support that, and what are the things that make it challenging to be continued. And you can see that playing out now in policies and directions that business has taken that have made these kinds of enterprises very challenging to be continued. Next slide. So wasn't all hard work though, and grew up in Jersey, and we spent actually a few years with my family at the in a same kind of large boarding house kind of setting, but it was at the Jersey Shore where I learned the joys of surfing. This was what a great escape, and this has nothing to do with policy, absolutely nothing at all to do with policy. But I just fell in love with, this was at a time when there was virtually no one on the East Coast anyway of the United States who was out there and getting surfboards and riding these little waves. But it was just an unbelievable joy and a freedom to be able to paddle out and catch a couple waves. And I can tell you that people that even back in the 50s and early 60s that I learned to surf with are still friends, and even at this late time in my life, I still enjoy getting out whenever I can and catching a couple of waves. Not the same big waves, but and preferably in warm water now, but I still enjoy that. Next slide. So, but other things impact your life, and I recall in the later 60s, and this is 1967, and this is Newark again, where I'm back living in Newark, and this is I think Broad Street, downtown Newark, and my then girlfriend her father had a beauty parlor. We were in the beauty parlor as tanks and armored cars rolled up the street. Buildings were on fire. Very tumultuous time. Both the Vietnam War and appropriate civil unrest, and highlighting racial disparities and discrimination, but a real foment of many, many things going on at the same time, but and culminating in these very violent kinds of episodes. We continue to see those, so they have not stopped. Certainly, different themes. We're still battling many of the same issues in terms of civil, racial injustice, poverty, other kinds of things that flare up and in our resolved in bits and pieces. better in many ways than it was at those days, but still not, I would say, totally in the, in the category where we could say, okay, we've now declared the world to be a fair and just place. But I drove out of literally left Newark in the rear view mirror in 1967 and headed off to college. And I can say it was probably with a pretty glad heart that I saw Newark fading away in the rear view mirror, because it was both a frightening and a very disappointing time that we would have to go through these kinds of violent episodes in order to bring about change. Again, here is another issue that really speaks to the importance of policies. But let's go on to the next slide. So moved on to the University of Rhode Island. I was fortunate enough to get a scholarship there. I think little because of my athletic prowess, which was modest at best, and perhaps a little bit more, because of economic need. But I was able to be able to go to college, and I felt fortunate to do that and search for what in the world, and with all the things that were happening in the world at the time, Vietnam and social and racial injustice and all of those things that were really top of mind for everybody. What was it that I wanted to get out of college besides getting out of Newark and trying to have a little bit of fun? And so I was really inclined, to the ocean, and I leaned toward marine biology. But I really found early on that so much history and so much revelation were things that were not necessarily coming out of what was happening right now, but could be found in classic literature of all kinds, and the classics going back to the Greek and Roman classics, and some of the Middle English and other writers. And I just fell in love with the classics, and spent just a lot of time really enjoying that literature, and still reflect back on that literature, and and many of the things that I do now, and don't know that impacts policy. But what is certain is that when you look at the classic literature, things that were written 1,000 or 2,000 years ago, that you can still see how policies influenced the lives of people back in those days. Some of it shines clearly through the literature, some of it you have to tease out. But in the end, so as you can see, it's 1967 to 70 was only 3 years. In the last year, you determined that out of all of these things, I in a very strange way, that I wanted to really help people, and the way that in a very tortuous kind of decision-making process, said I think going into healthcare and being a doctor would be a good way to do that. So I applied to medical school, got in after 3 years of college, but was able to get enough credits to graduate. A lot of people were graduating at that time early, because this was at the height of both the deaths in Vietnam, and also the protests against the war, Ohio State and others, and just for a variety of reasons, policies, state and national policies at that time drove a lot of decisions, and not the least of which was, did I want to go to Vietnam? And if the war was almost over at that point, but there was an opportunity to go to Vietnam. I had, you saw a picture of my family before, but cousins who were there, who I felt strongly I wanted to go to support, and at the same time felt strongly about not wanting to join in a war that would put me in a position of doing something that I didn't really believe in. So all of those things kind of conspired to say, let's do something that makes good sense, and let's see if we can help people and go into healthcare. And I was fortunate enough, next slide, to be accepted to a few medical schools. I chose Hershey, Pennsylvania. That's like the second year of existence of the Penn State University School of Medicine. It was a school that was built out in a cornfield. The money for the school was donated by Milton S. Hershey, who was quite a philanthropist. Hershey chocolate. He had been married, never had any children, amassed an enormous wealth, and said that he wanted to establish schools for orphans in Hershey, Pennsylvania. They still exist, schools on farms, and that he guaranteed with his bequest that, not having any heirs, that the graduates of those orphanage schools would have free education throughout their lives to whatever degree they wanted. Penn State took some of that money and said, listen, we are going to guarantee that those the young people who come out of these orphanage schools in Hershey, Pennsylvania, can also go to medical school for free. And had several of those in my class, several wonderful folks who came from those schools in my class. But it was a great experience, great time, very innovative, because everything was new. Everybody was finding their way around. All new faculty, looking, I think many of the roots of family medicine came out of the work that was done by a number of the were general practitioners at the time in that school. But I was particularly influenced by a couple of things. One is I got involved, and there was encouragement. Everyone was required actually to do research, and I got involved in viral research. Picked a mentor and did research with HPV, human papillomavirus. And the researcher at that time, and now this is in the 70s, his theory was that human papillomavirus could be oncogenic, could cause cancer. Never been shown before. We knew that it caused warts, but didn't know whether it caused cancer. So some of the earliest papers that I did were in demonstrating that that human papillomavirus, kind of transplanting it to skin that had been exoplanted on the sides of hamsters, but a human skin, that it could produce cancerous kinds of changes in that skin. So that led ultimately, many years later, to, I can recall, advocating for policies for HPV vaccines. Because along the way, we've discovered that human papillomavirus can cause cancer, and it's responsible for a certain percentage of oral and anal and vaginal and cervical cancers, and that vaccines can reduce that risk or eliminate that risk. And the policy pieces there continue, because there's a strong anti-vaccine contingent that I'm sure you're aware of, who have been very vocal at pushing back against policies that would either permit or require HPV vaccines as part of a routine vaccination program for adolescents and young adults. So there's a very clear linkage between an early influence and a very late policy making role. Also at that time, there was an introduction into healthcare of the humanities. And I would say medical school, it was not traditionally before that deeply invested either in kind of the social needs of people or in the humanities. But in this early new experimental medical school, the leadership brought on Dr. K. Danner Klauser. So Dan, and he became over many years a friend, was a theologian and a PhD, and a tremendously compassionate thinker, but also one who's deeply steeped in medical ethics and sociology, and was really a mentor in terms of injecting kind of this humanistic approach to healthcare, which before that was really very much treating everyone the same without concern for what their race or ethnicity is, but also without concern for what their individual thoughts, hopes, and desires are, or where they come from and what their social needs, met and unmet, are. So Dan kind of said, this is a business where we deal with human beings, and let's make sure we're dealing with them in a humanistic way. He came back, actually, I'll tell you about this, when in a later chapter in my life, and was even more influential. Been totally unrelated to probably to any policy. In my spare time in Hershey in medical school, for one reason or other, I decided to want to learn to play the piano. So I bought my first piano in medical school, and have not been without one since. So next slide. Finished medical school and was fortunate enough to get into Brown University residency in internal medicine, where I spent the next 3 years. As you will all find out, those residency years become a blur. I can recall many long nights that blended into the next day and then into the next night again. But learned a lot, made many friends, and still found time while there in Rhode Island to enjoy the place. Also, found a really deep understanding of the importance of medicine in people's lives. This was the advent during the time that I was here, really, of nephrology as a specialty and dialysis as a technique, and the policies, who gets dialysis and who doesn't, how we train and certify nephrologists. All of those things were in the hopper at that time. I can tell you, I was pretty much so busy with doing basic residency that I paid little attention to that. But thinking back about that in those days, and also thinking back about how Medicare, which was very new at that time, Medicare started in 1965, Medicaid in 1966, how that was beginning to influence the delivery of care, both mostly in a positive way, in this setting, was also something that I think back about now, although I couldn't tell you at the time, had little time or interest in thinking about policies at that moment. Next slide. A more interesting note, well, in Rhode Island, it's the famous Narragansett Bay, and at that time was a place where traditionally the America's Cup was run. I had met friends and neighbors, and they were all very engaged in sailing, sailboats. So I've always had a penchant for the water. And I would say that did escape to Narragansett Bay to surf from time to time while I was there, but really fell in love with sailing. And this succession you can see here is really a long succession. I started out with a little 15-foot boat, sailboat, and then moved up to a 20-foot boat that a friend and I decided that we'd sail from Narragansett Bay to Maine in very, very bad weather, which was a wonderful experience and one of those life-changing experiences, dodging a hurricane in a 20-foot boat. But I've just kept that as a passion throughout my life, and always had until recently one kind of boat or another, and find that, and again, probably totally unrelated, but as an escape from a lot of other pressures and tensions and things, find that getting out on the water has always been a wonderful passion. And later a business. I actually did start in Rhode Island, near the end of residency with a friend, started a charter boat business, initially just taking people out to see the America's Cups, and then in what's called term charters, taking families and couples, etc., out for several days or a week, to visit different islands and whatnot. First in New England, and then later in the Caribbean. And that was a mix of both a passion for sailing and a little bit of business. I would not recommend that to anyone as a business, but it was a fun thing to do at the time. So next slide. So I finished residency, and having the passion for sailing, had a boat. One of my cousins, one that if you go think back to the butcher shop pictures, one of those cousins actually came back from Vietnam, got some training as an accountant, fell in love with Canadian aristocracy, moved to Washington State, became an executive in a boat building business, making these boats that you can see on the left here called Valiants. And he encouraged and supported me in getting one of those Valiants that as I sailed off from Rhode Island to my now public health service commitment in the National Health Service as a physician in an island in the Caribbean, solo only physician on an island. I did it by taking that Valiant 40-foot sailboat from Rhode Island down to the island known as St. John in the U.S. Virgin Islands. So great adventure, lots of fun, a trip that subsequently I've made many, 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 many times with that boat and others, and wound up, and you can see the map here, about a 1,200-mile offshore trip that was a ton of fun and another one of those life-changing experiences. Next slide. And I wound up here at the Morris DeCastro Clinic, the U.S. Virgin Islands, where I served as the only doctor on St. John. It was a really a wonderful experience to be there, providing all the care for both the tourists on the island and also the natives, and really fell in love with the locals. Locals were a combination of African slaves who were brought to the island and mixed with the local Indian population, and they were very loving, colorful people who remarkably would use the clinic only after they've seen their local spiritual doctors, who would give them soursop leaves to wear on their heads and different kinds of teas to use. And if those things were not sufficient, then they would come and see the clinic, and then often ask people to take their hats off and leaves would fall out. And it's just a very but they're wonderful people. I got to provide all the care for them, delivering babies and taking care of the acute emergencies and the chronic illnesses, and understanding the culture and how different their culture was from our culture, and particularly seeing the juxtaposition of the culture of the locals with there was Keneal Bay, which was a Rockefeller resort that I also had the responsibility of caring for the tourists. So to see the concern that tourists would have with sand fly bites, no-see-um bites, and ask for home visits in their little huts that not little, but air-conditioned huts. In the kind of very opulent lifestyles and catered lifestyles that they had, compared to on the very same island, the natives who were living in shacks and tending goats and eking out a living to the best that they could. Was again really interesting in terms of looking at the juxtapositions of these two in the same island, and providing care to both. and understanding the disparities and the underpinnings of those disparities. I tell you, I fell in love with the people. I also treated occasionally their goats when they were injured, sick. And one goat, I recall setting a goat's leg after it had fallen off some rocks with a makeshift splint. It's nothing. Please don't confuse me with a veterinarian in any way, shape, or form. But I did, and as a result of that, was given 2 baby goats as a reward for that. And I'll tell you a little bit about the baby goats in a moment. But it was just a great experience again. And there was a dentist who I shared this clinic with. He was a Navy dentist. His name was Howard also. So the locals would come in and ask for Dr. Howard. They'd ask for the white Dr. Howard or the black Dr. Howard. So the black was the dentist, the white was the medical. It was just a fun experience there. And fresh out of internal medicine residency, it made me understand that internal medicine was not the only thing in the world, because I had to do virtually everything, including the OBGYNs and other kinds of stuff that came down the pike. So that was great in preparing me for the future. Next slide. I finished that tour of duty, looked for a position after that, and accepted a role with the state of California as a consultant, and also at UC Davis in the medical school and the Department of Medicine and Psychiatry. Actually, the position that I had was in neurochemistry research. I had desire to go back to doing research in a way that I had in medical school, and this opportunity came up. It was very focused. It was on neurochemistry, looking at things that medical conditions or the neurochemistry that leads to mental health disorders. And for the time that I was there, the entire focus was on that, looking for the underpinnings of those things that make us act in ways that are not normative: schizophrenia, depression, anxiety, et cetera, et cetera. There was one condition that was notorious for that. It's an inborn error of metabolism called metachromatic leukodystrophy. It's an aryl sulfatase enzyme deficiency. And we studied thousands of people with schizophrenia to see if that was in fact part of the neurochemical pathway that led to that. And it was not, but it did expose me to a lot more intensity in terms of benchtop research, and led to looking at lead levels in people with mental illness in the state system in California, and other medical conditions. A very broad survey of everyone who was held against their will in California, to see if there were medical conditions, hypothyroidism or other kinds of medical conditions that either caused them to have their psychiatric abnormalities or exacerbated them. And we, in fact, did find many of those. I worked in conjunction with a really pioneering psychiatrist who was at NIMH, E. Fuller Torrey, and not together with Fuller Torrey, but together with some other advocates, helped sponsor a bill in the California legislature. And again, this is now policy that required that individuals who go into psychiatric facilities have evaluations to make sure they, in fact, their general health is maintained, and the fact that they don't have any underlying conditions that are mimicking psychiatric conditions. And in those days, drugs, psychedelics particularly, were one of those. So it was a very important bill. It was passed in 1981 or so in the California legislature. That was one of a succession of bills that provided better care for people, and more freedoms for people who were in psychiatric facilities. Kay Danner Clauser, who had mentioned it, was a mentor at medical school, I recruited to come out there, and we established a few symposia on these issues. And then one focal issue that became a policy issue was the obligation to inform versus the right to privacy. So this was notably a case that was in the California courts at the time, where a patient was in a psychiatric facility and was known to be to harbor thoughts of harm against others, but was released. And the psychiatrist who cared for that person notably did not inform others because he felt that that was a privileged communication. So this person went out and heard other people. A court case pursued, and it led to a long discussion about this and policy regarding the obligation to inform harm, again, if there's a risk of harm versus the right to privacy, which fed into ultimately, a lot of the privacy issues that we have now, HIPAA and other, not directly, but colored the direction and the exclusions that we see in HIPAA now. So that was emblematic of the fact that out of controversies, we often have to develop policies that will be thoughtful and appropriate in order to avoid and to balance between two very closely aligned and almost equal kinds of rights that people have. I had really wonderful, funny experience in some of these state legislative bills that, for one reason or other, the Scientologists were very adamant and strong advocates for mental health rights. So much so that they believed that there wasn't really any reason for anyone to be in a psychiatric facility. There was no such thing as mental illness. And they used me on some radio and TV kinds of things in a way that I've now learned not to be used, to help them advocate in that way. So I'm not a Scientologist. There's many things about them that I would say I don't really support. But I was clearly used by them in that regard. But I stopped that association completely when, while testifying at a hearing in the California Senate, the Scientologists dressed up as chickens and went up and down the aisles for some reason to be emblematic about something. And I said, that's not me. I am not them. So just as a funny sidelight, just in perhaps a cautionary tale, as you go forward in your lives and you are an advocate and working on policy, be very careful who you choose as your colleagues, and make sure you fully understand their positions. Next slide. So Napa, and where I lived when I was in California, was this little place called Napa. Now it's very well known as wine growing and fancy area. I was fortunate enough to buy a little bit of land there when land was still cheap. This is me and my youngest son, my first son, I would say, not my youngest, my first son, in a little truck that I got out of the scrap yard, and had a wonderful time there. First two children in Napa, and a little farm where we raised a variety of things, and those two baby goats that I got when I was in St. John as the doctor, I eventually was able to bring them to Napa, and we raised those and bred those and milked those, and raised the first two children while we were in California on goat's milk and homegrown stuff. Has absolutely nothing to do with policy, except to say, a bit a bit of that still that still colors my life. The memories of that very earthy existence. Next slide. So it did had an academic role, as I said, at UC Davis, and was enjoyed very much teaching and clinical practice and research. Eventually, we left California. Just the grants that I had ran out. There was also that little farm that I had there. We had an earthquake, which didn't cause much damage, but then sometime after that, we had a wildfire. We had to be on the roof of the farmhouse as they dropped orange fire retardant around. And then following that, heavy rains and then mudslides. So this is still happening in California, as you all know. But it was enough to convince me to move back east. I shifted my academic affiliation to Georgetown, was on the teaching faculty there, and also and along the way, in the interim here, had also started some businesses. So one of the kind of the key things I in life is that, I had business in my early roots from the family businesses, and said, let me see if I can provide for my family by having some businesses. So I did start some businesses, and along the way also got a master's degree from Tulane, which was kind of a combination of both a business and public health master's degree called a MMM, Master of Medical Management. But all of that helped support the work that I was doing in the faculty at Georgetown, and also was fortunate enough to be able to teach at the McDonough Graduate Business School, teaching healthcare marketplace courses and doing special projects with the MBA students there. I still continue. I've I would say, a soft association with Johns Hopkins. I love working with the folks there. I've been appointed as an associate, but most of my work now is not in the academic role. Most of my work of recent is clearly in the public health and in the policy venue. Next slide. I've had in policy, and I would say those academic experiences do color my opinions and my direction in terms of policy. And I also understand from those academic roles the importance of how publications, objective publications, statistically significant studies help to underpin the opinions and guide policymakers in what they do. So that academic part is essential in terms of policymaking. It is not so much directly policy, but it provides the necessary objective information that helps, not completely, but helps guide decision-making for policymakers. I've done a variety of different things in my clinical practice. After I came back from California, I got boarded in emergency medicine. Also, I always enjoyed doing emergencies from the early days, moonlighting as a medical resident in emergency departments, and then in St. John providing emergency medicine because there's no one else there, and even in California moonlighting while I was doing research there. So I ultimately got boarded in emergency medicine, and then later moved to a primary care practice, established a solo practice, and then with the Georgetown affiliation grew that. But very interestingly, early on in this practice, one of the, and this is a very heavy influence in my life, one of the local nuns visited me, Sister Michaeline. She had the local soup kitchen and was doing a lot of other charitable things with the church. But she came to my office and she sat across the desk from me, and I still recall this vividly. She said, "Dr. Haft, don't you think we need to have a free clinic here?" And I said, "Sister, I really hadn't thought about it." And then she looked at me again with these, I don't know if you've ever you probably all had an opportunity to see a sister from time to time, but with these steely blue eyes, she looked across the desk and she said again, exactly the same. Dr. Haft, don't you think we need to have a free clinic here? Sister Michaeline, I was thinking we need to have a free clinic here because there was no question in anybody's mind that she was determined and she was a force of nature and we were going to have a free clinic. So we established initially in my office in the evenings, a free clinic, and then ultimately built a clinic with a free clinic with a lot of help and assistance and her same kind of advocacy with others, builders and legislators and others that still exists today. And what's heartwarming about this little story is that Sister Michaeline has moved on, retired, but she wrote a book, The Clinic That God Built, and she sent me a copy of that. And in one of the chapters, there's many chapters and great story. One of the chapters is exactly word for word what I had recalled her saying to me in my response to her when she said, "Don't you think we need to have a clinic here?" So that's indelible to me, and that has been, a mark of everything that I think of when I think about policy making is how we can not just help some of the people, but how we can help all the people. And I continue to support. I've worked as the director of this clinic, cared for many people, and continue to support that free clinic. Next slide. Along the way, I've also had the opportunity to do disaster relief many times during Katrina. I was with the Maryland Guard and served there. I think you all recall the devastation that was there, and again, not with the Maryland Guard, but with the independent, an NGO in Haiti after the earthquake, setting up clinics in the streets and doing emergency surgeries and on and on. And then in Jamaica, not with some with hurricane after hurricane, but a large amount of the work is shifted from disaster relief to more mission work and doing diabetes education and programs in Jamaica and elsewhere. And I find that just so rewarding to be able to respond in that way. But at the same time, understand that those responses, which are necessary and important, are not sustainable, and that they require, sustainable building of sustainable infrastructure and which requires decision makers, governments, and policymakers to understand that and build those sustainable infrastructures. I cite Haiti as an ongoing example of where that's not happening now. Next slide. So I have been also fortunate to, as I said, I had a penchant for business that started doing business at an early age with my family, but then subsequently, coming to Georgetown, one of the things that I did there was to work with them, develop some capital resources, and did mergers and acquisitions of primary care practices, building large network. I was in a startup telehealth company that became publicly traded that provided medical advice to ships at sea. This was taking advantage of a policy. So before we started this company, the U.S. Coast Guard provided free medical advice globally to ships at sea. For a regulatory change, I think it was a policy that changed, told the Coast Guard that they could not, either because of liability or cost or whatever the reasons were, they could no longer provide free medical advice to ships at sea. So with the knowledge of that change, we started a company that with radio towers and Inmarsat, satellite stuff, to provide medical advice to ships at sea. It was an interesting and good project, fun to do, made a little bit of money, and also was a great experience in doing a startup company. I started up a subsequent startup company called ConMed Health that also resulted from a Supreme Court decision, or the opportunity resulted from a Supreme Court decision. That was Estelle v. Gamble in 1976, which said that everyone who's held against their will, either in jails, prisons, psychiatric facilities, had the right to healthcare. And this is interesting because you remember we talked about rights and privileges. The only group of people in the United States who have the right to healthcare are those who were held against their will, which was established by Estelle v. Gamble in 1976 in the Supreme Court. So with that, it required every county jail, every prison, every psychiatric facility in the nation to provide health care to people who were held against their will. So we started a company locally and grew it to multiple markets, and then nationally took it public, and again did I think quite well with that. Always with the idea that we were providing high quality, compassionate care to people who were held against their will, and assuming the financial responsibility for that care. We also sponsored legislation in Maryland and other places, and this was by hiring lobbyists to advocate with policymakers to improve to lower the costs of that care and to improve the care for those individuals. As I said, we also started another startup, was a free clinic, which not for profit, obviously. It's been a joy investing in that, and started another startup of Maryland Foundation for Quality Healthcare, which was an entirely charitable organization that provided free diabetes self-management education to people who were uninsured or underinsured. And it's not all. Anybody who's been in the startup business knows that not every startup is successful. I had at least two. There should be more than that, but at least two electronic medical record companies that were DOS-based EMRs that didn't do well, went by the wayside. So, but they were fun. They were also fun to start. Next slide. So after all of that, all those experiences, you'll find that you will have experiences in your life. Every one of them will color your inclination to either to do policy or not. And if you're a victim of it, will color how you feel about it. If you're a policy maker or influencer, will color the direction that you'll want to guide that policy. But the important thing, I think, to remember is that the policies, statutes, and regulations are really the big drivers of change in the course of history over a long time. And you're either going to be passively the victim of those, or you will be involved in guiding the decisions of those. I think this is an apt quote from T.S. Eliot: "We shall not cease from our exploration. At the end of all our exploring will be to arrive where we started and know the place for the first time." And I think back to my family and working together with them and trying to make our existence better. And I think that's where we all are now, is trying to make the world somewhat better place. Next slide. So my family's grown. This is actually, they can't get them all in the lens anymore. We've been blessed with 6 wonderful children, and my wife is one of 7, and we've got grandchildren, and they've got cousins, and etc. But this is why I do things, because of those little ones that are there in the picture will be the future, and I want more than anything to make sure that their future is bright and strong. Next slide. So now I'll just so here's where I work now. This is the Maryland Department of Health. And now I'm really deeply involved in in policy making and in public health. And I've served in the Department of Health as first as Deputy Secretary for Public Health. I served as the Executive Director of the Obamacare, the Health Benefit Exchange, startup company, the Maryland Primary Care Program, which is like I've run it like a startup company, and now serve as a senior medical advisor. But all along the way, I've had such an incredible opportunity to work with our policymakers within health and within other divisions of the executive branch, and also with our legislators and in the real work of policymaking at the state level, and also to an extent at the federal level. Next slide. Just a couple of the bills that I've been involved with: the harm reduction bill, the syringe exchange bill, the opioid omnibus bill that has covered all of the aspects of how we respond to the opioid crisis. The reinsurance bill to lower the cost of healthcare under the exchange, primary care funding bill, collaborative care model, and then so many more that whether I've directly been involved or simply providing testimony in support of, or in some cases against the introduction of a bill and making a bill into law. Next slide. So there's many different paths. The most important thing that I can tell you, I think overall, is go where your heart leads you. And if it doesn't lead you to policy, wherever it leads you, if you're going where your heart leads you, at the end, at least you'll have fewer or no regrets. Public health and primary care are really fertile grounds if you want to go into that area to plant policy seeds that will grow into the future of our healthcare and our nation. But there are many other opportunities. And for me, this has been a wonderful and always changing 50-year journey in healthcare. And I hope your journey is even better. Next and last slide. Oh, there it is. So I think if you click on it, it'll maybe not. Sometimes in these formats, it's just reciting again this piece of a poem from Robert Frost. So I'll stop there. Thank you so much for allowing me to share this with you, and I'm happy to entertain your question.
Thank you for your mentorship and teaching, Dr. Haft. We'll begin the Q&A session right now. So my name is Hamza, and I'm a student in the BSDO program with Seton Hill University and the Lake Erie College of Osteopathic Medicine. To start off our Q&A, we separated your questions we received based on your presentation and based on your career. So we'll start the questions based on your presentation. What lessons from your time in the U.S. Virgin Islands did you learn that you wish would be applied across the United States?
So thank you. That's a great question. I think that the big lesson was that there continue to be disparities and a divide between the wealth and the opportunities of the very rich and the very poor. And we need to be really intentional about saying that, and intentional in our policies that will reduce those disparities in every way: the health outcomes, the economic opportunities, etc.
Thank you for that question. Now, you also talked a lot about business throughout your presentation. So it is well known that government jobs in the U.S. don't pay as much. So why do you choose to pursue a public service?
Well, I'll be honest with you about that. So I was very fortunate in the business endeavors to be able to be financially successful, so I can care for my family and in a way that I'm very comfortable with, provide for my children's education and give them a good start in life, and my public service now is a way of giving back. So you're absolutely right. The public service is not as highly compensable as is the private sector or certain business or some businesses. But in the end, it's not in the end. So someone told me this story once, and I'll tell you this little story since we've got a minute or two here. So, and this is going to be, it's meant as a joke, but it's a true story. So these two people die and they go to heaven, and in the first one, is somebody who has given in public service all of their life, and but they're now not very rich, and St. Peter greets that person at the gate at pearly gates, and takes them in and takes them to down a beautiful street that's lined with gold, and takes them to a mansion that is just opulent, and says, "Here's where you'll live in heaven." The next person comes to the gate, and it's somebody who's been absolutely successful in their life. They're used to living, high on the hog, and just done everything, that they could to be financially successful. And St. Peter takes that person through the pearly gates and walks them down this road that's paved with gold, and keeps going, and he goes to a road that's paved with tar, keeps going, and he goes to a dirt road and takes him to a house that has some grass in the front yard that's not well trimmed and shutters that are falling off, and says, "Here's your house." And the person says, "Well, I don't understand it. Why did that person get this beautiful mansion and I get this little house with a poorly trimmed yard?" And St. Peter said, "We can only build for you here in heaven what you give to us in advance." I think that's the message that sticks with me, is that it's not really what you have here, what you asked in terms of personal wealth, that makes a difference. When in the end, and it's not whether it's heaven or not, it's about how you feel about your life. It's not what you've gained monetarily. It's what you've been able to give to people, and how you've been able to make the world a better place. And you can do that, no matter where you are in your life, but it's so much better, so much easier to give that in public service, and to really feel the impact of what you're giving to the world in public service. So the balance is, and there's probably a sweet spot there someplace between being, having enough to live on, and knowing that you've helped the world in a substantial way. I hope that makes sense.
Yes, that does make sense. That answer is a really good one. Going back to, the work that you've done, what is a healthcare policy you're most proud of for its impact?
I would, well, there was not, I think the two things. One, the early work with mental health, and being able to ensure that people who have mental health disorders are able to achieve fair and appropriate care, is one. And it's not that I did very little bit of that, but it started a long progression of things that have grown over time. But most recently, I think it would be probably the Harm Reduction Act that we introduced, that allowed for harm reduction centers to exist at every place in Maryland. This is a way of combating stigma, and saving lives, and people who are in the throes of opioid addiction.
All right. Thank you. Now, this is a question regarding your free clinic that you ran, that you were mentioning earlier. How is funding done to keep it sustainable? Because obviously, the patients aren't paying for it, the insurance companies aren't paying for it. So how do you keep a clinic like that running?
Yeah, that's a great question. So, and one that, over the now 28 years or so of that clinic, maybe longer, had to deal with. Initially, it was all, volunteers and philanthropic and charitable support through fundraisers and those kinds of things. That's grants that later became a way of supporting the free clinic. But all of those things, philanthropy and fundraising and grants are very tenuous. They can come and go, and they're not really necessarily sustainable. We made the decision with the free clinic to begin to be a hybrid and accept Medicaid, and then grew from that to accept Medicaid, Medicare, and other insurances. But did that in order to really use that revenue, and particularly as Medicaid was expanded in the state, made it easier. The uninsured were fewer, although still a lot of undocumented individuals who are uninsured. But use the revenue from billable services from state and federal and commercial payers to offset the costs of care. And I think that's what's happening with a lot of free clinics now, that they're becoming hybrid free clinics, that they still provide free care, some sliding scales, but it's a challenge. We still have 6 or 7% of people in Maryland who are uninsured. And I will tell you something else that, and this may not always be obvious, but having an insurance card by itself does not guarantee access to high value healthcare. First, there may not be high value healthcare available because of long waits or other reasons, or geography. But second, more importantly, that those cards sometimes have associated with them high deductibles or co-insurance or co-pays that still make it very challenging economically for people to get the kind of care that they should get. So I'll get off that soapbox now.
All right, thank you. Now for our final question regarding your career. You mentioned a lot about business through your presentation. And can you go into a bit more depth about the relation between private business and public health agencies?
Yeah, I think that's a great question again. So number one, private business businesses all start with a particular purpose and a design. And the design will lead to what will be, considered to be profit in the end. And so investments are made, staff or resources are established to do a particular function, and there's an exchange of money for that function. And the net at the end is supposed to be profit. The profit will go back into the company or the owner of the company. In public health, we have revenues that come in, and they are put to purpose, but the purpose is not to produce profit. The purpose is to produce a better health for the individuals who are being served by this revenue stream. So in many ways, the lessons from private enterprise of you have money that comes in, and you need to take that money and be able to produce a program that will yield the results that you want and will lead to some margin of profit. The very same things happen in public health and in the endeavors that we have. But sometimes we don't think about it in that way. Sometimes we think about it, well, the money's come in and we don't really need to, here's the money. There's no sense of pressure, urgency, or time to turn this into a product of health, because we're not dependent on the profit coming out at the end. So I like to think about all of the things that I do in public health in terms of they're just like businesses, except what we're producing in the end. My profit is better health for the people that I serve, and I like to approach it like my hair is on fire. And I've got some revenue here. What is the funding for public health? And I'm going to use that and the resources that I have and the people that I have to execute this, just like it's a startup company. And the money, in a startup company, the money runs out. If you get to a point in a startup company and and whatever your investment that started you runs out, you're dead in the water. The end of company. And I've had that happen many times. Sad that, but it happens, but that's the game. I look at the money that we get in public health in the very same way. This money's going to run out. I'm going to make every bit of hay I can out of that investment and turn it into better health in the best way that I can, as quick as I can, because it's going to run out. That makes sense?
Yes, that does. Now I'll be switching gears into a bit more questions about your career journey. And now that you just mentioned startups and how money runs out and whatnot, this question isn't really related to that. But what made you decide to pursue startups to begin with? Like there's the one that you send medical equipment to ships at sea. What made you choose to go that route?
So it was taking advantage. The medical advice to ships at sea it wasn't equipment, it was advice, but it was because of an opportunity. Again, that there was a gap that needed to be filled. Ships at sea, tankers, freighters, commercial ships, and even pleasure ships. When they're out at sea, they have medical emergencies, and they need to have someone giving them advice of what to do, because obviously there's not a doctor or a skilled health professional on every one of these ships. So it was filling a need to do that, and so that was the reason for the startup. It also was an opportunity. Say, here's a need, but here's also they came out of a policy change on the Coast Guard side, but here's an opportunity to do good, to do well by doing good. And I think that's always a really good thing to think about. If you can doing well, whether it's financially or spiritually well by doing good, that's a good format. And startups are like that. Every startup is taking advantage of an opportunity that somebody that is either newly arisen, or is one that exists in that person's head, that they're going to make this opportunity arise.
Great, thank you for that answer. Now, why did you choose to pursue both internal medicine and emergency medicine specialties? Was it because of your disaster relief work?
Nah, sort of backwards. I did the emergency medicine before I did disaster relief, and I did internal medicine because that was my residency training. And actually, how I fell into emergency medicine was that I was moonlighting for both as an internal medicine resident, as a researcher in California, as an ER doc, and that was about the time that emergency medicine residencies just got started. They weren't always around, and they allowed an opportunity in the early days of those, to allow people who had a certain number of days or hours, I don't remember it, of clinical experience, to take the boards. So I had been doing moonlighting in emergency departments for a long time, had plenty of hours of experience, and I simply took the boards and got board certified, but didn't do an emergency medicine residency. It was that window of opportunity to leverage experience and take a board exam. But I enjoyed it, and I did emergency medicine kind of on and off for a decade after that, and it was something that emergency medicine is rewarding, it's exciting, it is the hyper acute version of healthcare, and I think it prepared me for doing and kind of kept kind of the spirit going for doing the disaster relief stuff. So in disaster relief, they look for people who have emergency and surgical experience largely. So that it opened that door, and a door of which I gladly go through.
Thank you very much. Now, to wrap up everything we're talking about your work in both internal medicine, emergency medicine, disaster relief, startups, public health, with all of your extensive roles in policy and healthcare. How do you manage your work-life balance?
So good question. That's a great question. So, and I would probably answer that if I was, being honest, that I don't manage it well. um, but it's but over time, it's something that I've gotten comfortable with. So I think it's because I really enjoy the work that I do. I really love the work, and every one of the things that I've done in my career, I've just tremendously enjoyed and wrung every bit of excitement and invested every bit of myself in every one of those. And I like to look at it that when it even as making changes, that I leave it all on the field before I go on to doing something else. So when I can do things that are not, the work that I'm doing, I like to do them exactly the same way, whether it's surfing or sailing or skiing or traveling with a family or whatever it is. I like to do that the same way, and then just make sure that that's a full and complete experience, and it holds me over until to the next time I get one of those other full and complete experiences. So it's probably not the best way to balance work and life, but here, after 70 something years, I'm okay with it. I wouldn't recommend it to everyone.
All right. Thank you very much, Dr. Haft. These are all the questions we have for today, and we really appreciate you taking the time to mentor us today.
It's my pleasure. Absolutely my pleasure. I hope that it's helpful, and I wish you all well and enjoy your journeys. And wherever your journey takes you, make the most of it. And look at it in a way that you gain from your experiences, and let those experiences guide you in the most positive way in the future. And I hope that you will be the people who I can look to create the past for my children, grandchildren, great-grandchildren, and make it a better world. So gracias to all of you also.
Now, I'd love for everyone to please give a warm thank you to Dr. Haft in the chat box for this incredibly important session. Thank you.
You're welcome.
Now we're going to conduct our closing session with our quiz and future session dates. The link to the quiz for this session is now live, and you'll need a 70% or higher to pass and receive certification, as always. The link to the quiz has been sent in the chat. And onto our next session dates, which will also be posted throughout our social media outlets, so be sure to follow us at TeleShadowing. Our next live session will be next Saturday, February 11th at 10 a.m. Eastern Standard Time, with a physician mentoring us in radiology and academia. Thank you so much, everyone, for attending today's session, and we hope to see you in upcoming sessions as well. This concludes this week's shadowing. Thank you.